Sure. So, we've done a lot of work on rapid diagnostics, especially for pneumonia. We've worked a lot with the Unyvero system, and we were part of the study that got it FDA approved. And so we have a large cohort of patients we've sort of analyzed along the way. But one of the things with rapid diagnostics, these big multiplex cartridges, and we've seen it with many different syndromes, is that you have a lot of negatives, and they tend to be expensive. So there's this whole, how do you decide who to use it, when to use it? How do you decide this is the right person to use it on, and this is going to give us a benefit that's worth the cost? So what we wanted to do is look at how could we try to improve this in a way to make it more likely that the people you use it on are the right people. So we went to a commonly used scoring system for pneumonia, the DRIP score, which is drug resistance in pneumonia. And the DRIP score really is a very simple way to kind of say, this patient likely needs broad spectrum antibiotics, this patient likely doesn't need broad spectrum antibiotics. So we analyzed all of our patient cohort with the DRIP score, and then we analyzed them, we had them the data from this Unyvero LRTI panel, and then we sort of combined them and we said, is there an additive benefit? And what we found is that if you just use the DRIP score as your initial cut and say, we're going to run the panel on the patients who have a DRIP score of 4 or more, which is the cutoff, you catch almost everybody who has a drug-resistant pathogen. You really miss only an additional 7 patients for MRSA or Pseudomonas if you cut it out, but you save 100, about a third of the people that you don't have to run it on. It's actually a little more than a third. So it's a significant cost savings without a significant loss of sensitivity. And if you were using the DRIP score alone, you would have missed those patients anyway. But the other thing that happens is the DRIP score has been shown in multiple institutions to really cut down on overuse of antibiotics, overuse of broad spectrum. But those patients that have a high DRIP score, they usually get both a MRSA agent and a Pseudomonas agent. In our cohort of 442 patients, there were only 12 patients that actually needed both, right? So an additional benefit of using the panel is you can selectively say they need vancomycin for MRSA, they need an anti-pseudomonal for Pseudomonas, and not have both agents on. And on top of that, there were 80 other resistant organisms that we caught that need a different antibiotic. So like, ESBLs or Acinetobacters, carbapenem-resistant Acinetobacters, KPCs, all of those got caught by the system, and DRIP wouldn't have told you anything about those. So combining them, really, you get incredible antibiotic stewardship from the panel, and we used the DRIP score to give us diagnostic stewardship for using that panel. Yeah, so the important takeaway, look, there have been many of these panels generated for many different syndromes. Everybody agrees that they help in the right patient, right? They can be a significant improvement in antibiotic stewardship. We find out this is the patient who has MRSA, this is the patient who has Pseudomonas, this is the patient who doesn't have any detectable bacteria, right? That's great. There's a cost. And right now, the cost is still relatively high compared to culture. The benefit is speed, right? We can get results back in hours rather than days. And when you're talking about a sick patient who might need the right antibiotic at the right time, they really help. But if you were to use it on every potential patient, you could potentially bankrupt your lab, especially if you start introducing lots and lots and lots of different multiplex panels. So every patient with a suspected infection gets a multiplex panel or 2 or 3, right? Now a patient comes in and looks septic, they get blood culture, urine culture, respiratory culture, procalcitonin, you name it, right? Now imagine you did a molecular panel for every one of those, a urine and a blood and a respiratory. You have to have a way to select who needs these panels in order to make it cost effective and still give you all the benefit. And that's what this really was. It said for the pneumonia patients, if you use this cutoff, you will catch most of them and really cut down on extra runs, extra cost. And really, even now, you still catch a number of people with that drip cutoff that don't need antibiotics at all, or at least don't need broad spectrum antibiotics. But you've significantly cut down the excess use of the system.